Assalamu alaikum. Thank you very much for being here today. I really appreciate you coming. I just came from the Kufa University and I had a session there for 2 hours. And I really was very happy because there was a lot of interaction. And I hope and wish we will have the interaction here as well, inshallah. My name is Ali Nورس. I'm one of the gastroenterologists and I'm the chief of gastroenterology at the University of Toledo. I left Iraq when I was 16 years old. And I've been at US in about almost 30 years. There are many things that we usually do at US a little bit different than here. So I would like just to go with you over a few things. I have a question to ask before I start my lecture. How many of you would like to pursue studying abroad? abroad. يعني هقولها بالعربي. كم واحد منكم ناوي يريد يرغب على الأقل كرغبة إنه يكمل دراسات بالخارج؟ إن شاء الله هنزين. غالب الناس بتكلم بالعربي. لأن العدد تقريبا ترفض وأنا سيد بالعربي. أوكي. So let me just, many of the questions which I'm going to ask, they are board questions. And they're going to be asked you, if you are taking the exam, if you plan to study at the United States, there will be a question that exactly like the one I'm going to mention in the USMLE 1 and USMLE 2. So I have 3 topics. They are all cases. You know, in the beginning I thought I'm going to give lectures. But I thought, probably giving a lecture, you already probably have many lectures. So I thought I would make it a discussion-based session. Now, the 3 topics I prepared, I want you to tell me which one you prefer me to go over. Because I don't know if we're going to cover all 3 of them. The second thing, I just want to tell you up front. Anyone wants the slides, I'm more than happy to give the slides. So you don't have to write. I want you to pay attention and get more engaged in the discussion. The slides, if any of you have a USB or give me email, I will send it to one person, everyone can take it from that person. So the 3 topics that I chose, because I thought these are very relevant and you see them very often. One of them is GI bleeding. The second one is obstructive jaundice. And the third one is dysphagia and heart rate. So, I just want to know which one you want me to start with, and that's based on your need. Which one you think you need more information to go with?
GI bleeding.
GI bleeding is I go by majority. Sorry, I know you're the representative, but GI bleeding is good? Okay. Then we'll start with the GI bleeding. So before I start, I might not go over all the slides, because I'm going to give you the slide anyway. The point to make is the discussion. So when we say GI bleeding, how do we recognize the patient has GI bleeding? Yes?
Either melena or hematochezia.
Or anything else other than melena or hematochezia?
Bala. Indicate for palpation in this superficial.
The pallor, it means there is anemia. Anemia could be from many things. Could be from hemolysis, could be from many reasons. But for GI bleeding,
Internal bleeding.
Yeah, you said there is melena and
Hematochezia.
Is there any other form of GI bleeding?
Intraperitoneal.
No, GI bleeding. hematemesis. So usually there is hematemesis, hematochezia, and melanoma. And what do we call this? We call it overt. overt GI bleeding. يعني شنو overt؟ يعني أما المريض بيصير or the physician will see. There is a blood. You can see the blood. So one thing to know about this, you don't use hemocold testing for it. Then hemocold testing, it's only for upper GI, not for overt GI. يعني أحيانا يجي طالب هنا يقول لي إنه this patient I think has bleeding and I did the occult blood test positive. I go, what's the symptoms? When he's passing the bright red blood. If he's passing the bright red blood, I don't need to check the occult because there's already overt GI. So, when we say hematemesis, hematemesis in which form can be? Is it the bright red blood? It could be streak. It could be 5 liters. Right? The amount varies from streak to as much as you want. So that's blood, fresh blood. What other form of hematemesis? What else? Any other form? You know what is coffee ground emesis? What does coffee ground emesis? It's like digestive blood. When the blood is not very quick and less amount, especially if it sits in the stomach longer, the bile will mix with it, it will come coffee. How about hematochezia? When there is hematochezia, what is the color of the stool?
Dark red.
It could be bright red blood, or it could be maroon color, right? Okay. Well, how about melanoma? Black stool. Okay. So melanoma, what does it mean? Does it mean upper or lower? Okay. Well, how do you define upper GI bleed? Which part of the GI tract can cause upper GI bleed? From where to where?
Above the gastroduodenal ligament.
Ligament? Ligament of Trias. Okay. What is ligament of Trias? Anyone knows what is the ligament of Trias?
From the second portion of the duodenum?
No. I can show you a picture of it. This is the ligament of Trias. You will hear it a lot. People tell you upper GI tract bleeding above ligament of Trias or below the ligament of Trias. So ligament of Trias is a sling. Connect the junction between the duodenum and the jejunum with the crura of the diaphragm. What's the function of the ligament of Trias? Yeah. So if someone doesn't have ligament of Trias, what's going to happen? They will have malrotation. Because this is like a sling holding the bowel. So that's the definition which we used to use always about upper versus lower GI. Now, there is a new definition. Because there is upper GI bleed, there is small bowel GI bleed, and there is a lower GI. What's the difference? Why it became like this? Because now we have many tools we can examine the small bowel with. We can do capsule endoscopy. We can do single balloon enteroscopy. We can do double balloon enteroscopy. We can do CT enteroscopy, or we can do MR enteroscopy. All these can examine the small bowel. Before, many times, we could not get deep into the small bowel. Now, we can almost examine the entire small bowel. So that's why this became a separate entity. So then, what is the upper GI bleed now? From where to where? It's the length of the scope. So if we do upper endoscopy for someone, where do we reach? If someone comes I said, you need an EGD. You call it OGD, I think. You call it EGD. I do EGD. Where do I reach? What level? The length of the scope. Where does it take you?
End of the duodenum?
No, not end of the duodenum. Second part of the duodenum where the papilla is. Maybe a little bit more. But that's the length of the scope. So that's what we call it upper GI bleed. يعني upper GI bleed, I can diagnose it with upper endoscopy. A small bowel GI bleed from the papilla to the ileocecal. كل small bowel. The lower GI bleed is the colon, from the rectum to the ileocecal bowel. Okay? Now, when we talk about upper GI bleed, there are certain causes for upper GI. What is the most common cause of upper GI bleeding? Peptic ulcer. Does it mean the ulcer is in the duodenum or in the stomach? Sorry? Both. Ulcer in the duodenum or ulcer in the stomach is considered peptic ulcer. And what is the most common cause of the peptic ulcer? And enzymes. Now, if the patient has an ulcer in the duodenum, where do you think the H5? This is a board question in the USMLE for people who want to take USMLE. They will tell you someone is coming. I'm going to tell you two questions, and they're both there. And actually, when you prepare for USMLE, there is a Q-bank. Questions. They call it U-word. They are in the U-word to prepare you for the exam. The first question is, they will tell you which ulcer has the least risk to have a cancer, to develop a cancer. Esophagus, stomach, duodenum, colon, small bowel, digestion. Duodenum ulcer is what? Is the less. Then they will tell you if someone has ulcer in the duodenum, which part of the stomach, if you biopsy, part it means gastric cardium, gastric fundus, gastric body, gastric antrum, down to the pylorus. Which part, if you diagnose, if you biopsy, you have a higher yield to discover H. pylori. If the patient has an ulcer in the duodenum, if you tell me which part, you have to tell me why. Yes?
Pylorus, nearest part of the duodenum.
No? Anyone else? Okay, you can tell me without telling me why. Which one? Sorry? Antrum. Excellent. Why? Based on what? No. The reason why. What are the cells in the antrum? Anyone knows the name of the cells in the antrum? I want the people who are in the back. The last line. The last people. Can you tell me what the name of the cells in the antrum? Where is the parietal cells? Which part of the stomach? Parietal cells, where it is? Sorry? Body. Excellent. Okay. So parietal cells, what's in the antrum? What cells you have in the antrum? Please, if you answer, just speak louder so I can hear you. You know? So in the antrum, you need to remember two cells, because in the exam, 90% of the question about those two cells. One of them is G cells, right? So what does G cell secrete? Gas. What is the other cell? D cells. Somatostat. Okay. So the G cells secrete the gas. D cells, somatostat. How does the gas work? The G cells secreted gastrin. What does the gastrin do? Yeah, because whatever is going to affect which cells? The parietal. So in the antrum, the G cells create gastrin. The gastrin will stimulate the parietal cells in the body. And then what does that do? HCl. Okay? Now, what is the function of the D cells? The somatostatin, what's the function of that? Sorry? Inhibitor. Of what? Of the G cells. Excellent. So now, can you explain to me why when there is H. pylori in the antrum, it caused ulcer in the duodenum? Yes. High. ليش؟ لأن ال H. pylori in the antrum is going to target which cell? No, the D. So there is no inhibitor. Too much gastrin, too much acid. That's why when the H. pylori in the antrum, it causes ulcer in the nearby area, which is the duodenum. Because it affects the D cells, there is no inhibitory factor, G cells goes up, it affects the parietal cells, acid. Right? Okay. What if I flip the scenario? If the H. pylori is in the stomach, in the body, what's that going to do? Sorry? Acid goes up or down? Why? Excellent. Because the bacteria affect the parietal cells. Remember in the antrum, it affected the D cells in the body, it affected the parietal cells. Parietal cells becomes atrophic, there is no acid. What's going to happen to the gastrin? When there is no acid, what's going to happen to the gastrin? لأنه trying, يحاول يصعد الأسيد. Because there is no acid, right? When you eat, the gastrin goes up. Then the food mixes with the acid will go down low. So the gastrin try to make it up. So what happens when the parietal cell grows and no acid? Get atrophic gastropathy. Atrophic gastropathy will lead to gastric cancer. So if someone asks you, H. pylori in the antrum, it causes more ulcers in the duodenum. H. pylori in the body, it causes atrophic gastropathy, possible cancer. Both cause what? High gas. And I cannot write on this anymore. Okay. Yeah. So my question is, since we are talking about this, there are 4 common causes for high gastrin. They ask you about them in the exam. Almost always. If you see a patient and someone tells you that the gastrin of this patient is high, what do you want to think about? We already mentioned 2. One is the H. pylori of the antrum, because there is no D cell, there is high gastrin. Second, H. pylori of the body, because there is no parietal cell, there is high gastrin. What are the other 2 causes? Common causes. There are more than 4, but those 4 are common, and they ask you in the exam about them. What are the other 2 common causes of high gastrin? Anyone knows? I couldn't. Tumor is creating gastrin. Excellent. What do we call that? What do we call it? Chisholm. Yeah. Ahsan. Z-E. Zollinger-Ellison. What is Zollinger-Ellison? Tumor is creating gastrin. Where is the tumor? Okay. One said greater curvature. What did you say? And one said pancreas. You are all right. The gastrin, the tumor is where? Is an area they call it Ahsan, triangle of gastrinoma. Where is that triangle? It's a triangle. The top part is the cystic duct with the bile duct. The second is the junction between second and third of the duodenum. Third is the head with the body of the pancreas. You know, most of the tumors are there. Okay? So now, what is the fourth common cause? By the way, Zollinger-Ellison, what are the symptoms of it? How does the patient present? How do you make a diagnosis? Number one, multiple small bowel ulcers with or without gastric ulcers. So high number one, multiple ulcers. That could be with a bleeding. What else?
So hypoglycemia?
Sorry?
Resistant.
Yeah, you have to give high dose PPI. Anything else? Yeah, but other than ulcers. Anything else? Chronic diarrhea. And when high acidity interfere with the absorption of the food. What else? Multiple what? Hydrogen one sometimes go, بس هو السيمتومز مالت الجاسينوما شنو؟ The other one, severe reflux, esophagitis. Severe ليش؟ لأنه there's a lot of acid. And big rugites, gastric rugites. Why there's big gastric rugites? Then there's hyperplasia, too much gastrin coming to the parietal, now it's getting big. So if someone coming with severe esophagitis, big rugites, multiple small ulcers, with or without gastric ulcers, and diarrhea, you need to check the gastrin level. If it comes above 1,000, that's diagnostic. If it comes below 1,000, you have to make sure there is no other causes before you do a test to confirm this gastrinoma, and that's called secretin stimulation test. When you give secretin, gastrin should go down, but if someone gastrinoma, you give secretin, gastrin goes up by 200. Now, there is another cause for gastrin. Which one? Did you want to say anything? Sorry? I repeat it? Which one of them?
The least. Or the taste of 1,000.
Oh, the taste, I'm sorry. When we check gas level, you get three possibilities. Either they are below 150, that's usually normal. Or they are above 1,000, that's usually diagnostic in most of the time for ZE, in the right setting, with the right symptoms. But when it comes in the middle, it's not normal, it's not above 1,000. يعني بالجراي zone. Then it could be يعني مثلا gasoline level 400. Okay? You don't know if it's gasoline level or not. Usually it should be about 1,000. But is it possible to be gasoline with only 400? Yes. Is it possible to be other causes? Yes. So how do you differentiate? Number one, you get a good history. So which medication can cause high gastric? Yes. أحسن. PPI. You put someone on PPI, the gastric will go up. Why? Why it goes up? Why the gastric goes up? Accept and it's blocking the proton pump, the parietal cells. So there is no acid, gastric goes up, trying to make up. Okay? So now you get four causes, common causes. Two of them H. pylori, one at the body, one at the antrum. One is PPI, and the other one is ZE. And if you look at them, the H. pylori of the body, it will cause something very similar to ZE. And the H. pylori of the body, it will cause something very similar to PPI. يعني إذا نخلي جدول نكتب gastrin and pH. So which one cause high gastrin with high pH? High pH يعني حلوة. Which one? No, the tumor will cause a lot of acid. Okay, I'm going to show it to you.
Also,
Yeah. Let me just repeat it. It's very, very important to understand it. لا تحفظوها. لأن if you try to memorize it, you will forget it before I read the book. So try to understand. أعد مرة ثانية. If there is H. pylori بالانترا, الجاسم راح يصير أعلى. How about acid? Too much acid or too little? Too much acid, صح؟ زين. إذا الواحد عنده زون جراليسيس، الجاسمين هاي، too much acid ولا لا؟ too much acid. A lot of acid, لأن الجاسمين هاي، فرايتر is normal. فذني الشعب. المشكلة لو عندي شيء على اسمه كان عرفت بالضبط شنو بس ما هالشكل صعب. Let me just ask you another question. So we say, okay, there are several reasons for high gas level. We're still talking about the upper GI bleed. We mentioned there are 4 common causes of upper GI bleed. One of them we talked about ulcer. What is the other common cause of upper GI bleeding? Yes. Yes.
Is it like a virus?
Ahsan. Varices. It could be esophagus. It could be stomach. What else? 4 most common causes of upper GI bleeding. We said ulcer, varices. What other 2? Yes? Mallory Weiss tear. Okay. How do they give you the exam the question? I will give you one scenario. They will tell you there is a pregnant lady coming with hematemesis. Okay? And you are interviewing the lady, asking her what happened. She tells you, I vomited the blood. You know, when someone vomited blood, they bring that person to the doctor. Because it's scary. I vomited the blood. What do you need to ask her to think that this is more likely to be malarial virus? What question?
The ones of the vomiting. The episode of the vomiting. With the vomiting.
The episode of vomiting is what?
That is increased, that the patients has the high vomiting, so that's either that space.
There is one question is usually, that is the exam that will tell you.
When time vomiting after drinking the rest?
No, you're pregnant, he doesn't drink. Yes. The question you ask, yes?
the association between the blood and the cough product.
The question you ask, what was the first vomitus? If the first vomitus there is no blood, the subsequent one had the blood, that means most likely, if someone is having GI bleeding, not from malarial virus, the first time they vomit there is a blood. But with malarial virus, the first, maybe second, maybe third, they are okay. Subsequent one. Why? I will ask you why. I will answer this in 1 minute, but there is a question in the board. What is the mechanism of malarial virus? Before I tell you why. What is the mechanism of malarial virus? Why? You know what is malarial virus, by the way? I want someone to answer from the middle line. Anyone knows what is malarial virus? Is there anyone else? What is malarial virus there? Fissure what? A junction between the esophagus and the stomach. Okay, why? High what? Where the pressure high? It's intra-abdominal pressure increase in the intra-abdominal. That's a pathophysiology. فيصير tear. التالي يسبب شنو؟ survival. That's a mechanism. Now, that's only superficial tear. If the tear is deep, gets through the wall and causes pneumomediastinum, what do we call that? Bornhab syndrome. Bornhab syndrome. That means they're already, the tear is not anymore superficial. It went through the wall. That's called prolapse. So we said Mallory-wise, we said varices, peptic ulcer. There is one more. Very common. It's reflux. Severe reflux. Very often people come vomiting blood. Usually it's not a lot, but they vomit because there's a lot of ulceration and inflammation in the esophagus. Those are the most common. Now there are other causes for upper GI. Traumatic, but there is one. I will ask you one. If someone had surgery, is there anyone doing surgery here? Okay. If someone had surgery, they have AAA. You know what is AAA? It's abdominal aneurysm. Okay? What? And they had surgery because they had aneurysm. Okay? What kind of surgery do they do? They put graft. Sometimes done endoscopic. By vascular surgery. So there is a graft. And the patient, that's why when you take the history of the patient with a GIP, it's very important to know the details. And I'll show you one slide. It's very important to know. I'm sorry. I think I passed. Because of what's the problem can happen. If someone has a graft and coming with hematochezia, what do you think is the problem? Anyone think about it? What is in front of the, what is touches the aorta? No? It's the third part of the duodenum. So sometimes the edge of the graft irrigate the third part, there is a communication. So what happened? The aorta started bleeding in the GI tract. And that can cause aortoenteric fistula. How do you diagnose it? CT with IV contrast. What happened? What do you see?
After we can take the results of the sections and we can see the integration between the aorta and the
You see the extravasation of contrast from the vessels to the gut. When you do CT with angio, the contrast should not leave the vessels. But if you see leakage in the GI tract, you know there is a communication. I have a question. At the end, I don't know if people, maybe they should come sit front because I don't know if they are with us or a different place. I can ask question, I will have the last 3 rows to answer. Okay, are you with me? The last 3 rows? Can you raise your hand? The last 3 rows, can you raise your hand? الصفوف الكاملة الأخيرة تقدرون تصعدون ايدكم؟ Okay, the question for you. If someone is passing blood per rectum, is that upper or lower? If someone is passing bright red blood per rectum, is that upper GI or lower? So maybe upper, maybe lower. 85% is lower, 15%. How do you differentiate? How can you tell? أريد الصفوف الكاملة الأخيرة حتى يسمعون وياي. Okay. لا أنت أرجع ربك. Anyone from the back? يعني if someone sitting in front of me, they are passing blood per rectum. I need to decide, am I going to go with the spot from above or from below? How do I decide? Is this upper 15% or this is lower 85%? Anyone? هل يسمع؟ لا. Okay, أقبل بالصفر. Yes. Sorry? اثنيناتهم could be fresh. They both can be fresh. The color can be same. Sorry? Both can be same way. Sorry?
يعني لو upper GI bleed واصل للور واحدة فريش معناها severe bleeding الستيج 1 ده هيكون يعني
Excellent. That's the way how we know. يعني if you have a patient and fasting the blood rectal, and you're not sure, is it upper or lower? يعني مثلا مريض elderly، الelderly معظم الأحيان lower could be upper، ويأخذ NSAIDs ممكن يكون upper. So now I'm confused. Then what is the most common cause of lower GI bleed? At least in the United States, what's the most common cause? No, cancer is not very common. Cancer is anemia from bleeding. Diverticular مو هرمونال، diverticular disease. يعني الأوت باوتش. Second most common is what? AVM. هذا اللور GI. بس المريض ياخذ NSAIDs. I can't tell if it's upper or lower. How much, this is the question, how much blood you need to lose in the GI tract to have the upper GI bleeding coming down right, not melena. Let me start with the question different way. First we'll start with melena. How much blood you have to lose to make your stool melena? Yes?
15.
More than that. It's about 150 ml. 150 ml. If you lose from the upper GI, the stool will become melena. How much blood you need to make the stool right if the blood is coming from above? How much blood you need? It's 1 liter. Yes, answer هذا السؤال. Then this will explain how we differentiate. If the patient sitting in front of me and telling me I have lost, I'm passing blood. I look at the patient. If the patient got a rigid على رجل, they saw if we are. He is not in shock. What do you think is the bleeding? No. لأنه forever المريض شنو يكون؟ pale, dizzy, orthostatic hypotension, cannot sit in shock. No. فإذا ما موجودة it's helpful. But if the patient in shock, you cannot tell it's upper or lower. لأن الأبر ممكن يخلي بالشاك واللور ممكن يخلي بالشاك. But if there is no shock, it's not upper. يعني negative shock helpful. But وجود الشاك is not helpful. فبالامتحان إذا يجي واحد يقول لك هذا المريض ما يقدر ينزل. There is a blood, sometimes they give us a lot of blood. لأن تعرف اللور يبين a lot. الأبر نص بعدها موجود بالجي اي تراك والنص الثاني برا فما يبين في اللور. إذا قلت لك إنه المريض you are seeing there is blood in the stool and the patient not in shock, you can say this is not upper GI bleeding, this is more likely lower. So the hemodynamic status what tells you what to choose. Okay? One other thing, if someone has, I want to see if anyone knows this answer, because this is a broad question for the individual somebody. Yes, in your pathophysiology, could it be pathophysiology? They will ask you somebody. Someone has severe aortic stenosis. Severe aortic stenosis coming with GI bleeding. What is the pathophysiology? What is the condition? Other broad question. You go look at each married, he has significant, severe aortic stenosis. And the patient is passing, and we go look at melena, or we go passing by blood. Yes?
Portal hypertension?
No.
السندروم angiodysplasia بس ما اتذكر يعني الاسم السابق.
أحسنت. That's very good answer. I'm impressed. يعني هذا السؤال يعني usually people are a little bit higher than me. Sometimes I like to challenge this thing. Something a bit higher than. What's the name of that syndrome? They call it Heidi's syndrome. شنو هو Heidi's syndrome? Yeah, but why that happens? Why? What is the pathophysiology? Why the angiodysplasia bleed when someone has aortic stenosis? They call it acquired von Willebrand factor deficiency. شلون؟ أو شلون ممكن؟ This is the slide. I don't know if you guys can see it or not. هذه الجهة هاي normal وهاي الجهة abnormal. يعني جهة اليمين اللي بها aortic stenosis وجهة اليسار there is no aortic stenosis. When there is no aortic stenosis هذول الثلاثة السلايدات اللي على اليسار. The von Willebrand factor هو دايما يعني مثل coil like this. هذا هنا. اوكي؟ فلما يجي يدخل through the aortic valve, it's normal. It passes like this through the aortic valve. When it passes beyond the aortic valve, هذا الانزيمز اللي ADAMTS13 cannot cleave it. لما هو اثنين dimer, it cannot cut it. So it's لما coil. So it keeps passing, and then when it gets to the site where there is some injury, it uncoils and it gets to that area and it gets stuck with the collagen and with the platelets and stop the bleeding. بس لما الواحد when there is severe aortic stenosis, what's going to happen? That dimer will separate. When they come two separately, other catalyzing enzyme will cut it, so it won't be functional anymore. That's why the patient bleeds from the AVM side. You remember this? Can you look here? We said that there is H. pylori in the antrum. Just two things I want to just talk about this, please. حتى بس we can get all over it. احنا قلنا إذا المريض عنده H. pylori بالانترا, what's going to happen to the gastric? Increase. What pH? pH. لأنه أسيد. هاي أسيد. صح؟ يعني شنو؟ هسه راح أرسم هنا. عندي صورة. Okay. This is the picture. Automatic confusion. This is the G cells. This is the D cells. If the H. pylori is here, this is killed. Too much gastrin, too much acid. يعني the pH goes down. صح? pH down, too much acid. pH up, less acid. Okay? That's one. الحالة الثانية اللي does the same thing is ZE. Zollinger-Ellison. Too much gastrin, too much stimulation, too much acid. فالZE والH. pylori of the antrum, same thing. They both cause high gastrin, high acid. High acid. Okay? Now, when we talk about here, H. pylori of the body, it affects the parietal. Gastrin goes up because it's trying to make it up. But the pH is what? High or down? The pH. If the H. pylori here is a pH up or down, quickly.
Down. pH down.
pH up. لأنه ماكو acid. If we kill the parietal cells, there is no acid. لما ماكو acid, the pH up or down? Up. صح؟ Up pH معناته ماكو acid. Down pH and too much acid. صح؟ So this is what it is. If the patient is on PPI, while their gastrin goes up, this is blocked. There is no acid, gastrin goes up. Similar to H. pylori here. And I don't want you to memorize. I want you to understand that memorization ما يطول من الأربعة. But if you understand it, you're not going to forget. Okay? فهذا نفس الشيء اللي صحيح بينهم. All right, so let me just go over another question. If the patient has significant GIP, upper GIP, which part of the stomach usually, or the duodenum, causes significant GI bleeding that many times is hard to control? Which, yes?
Posterior part?
Posterior part of what?
The second part.
Sorry?
The gastroc, the stomach.
Posterior.
No.
Junction between stomach and duodenum.
The posterior wall of the duodenal part. That's in the duodenum. Which part of the stomach? That's another one. And you have to tell me why. Why those areas are very high risk for bleeding?
Adjacent to the blood vessel.
Which blood vessel? That's the question. Excellent. So for posterior wall duodenal part is duodenal artery. Duodenal artery is which branch of which artery? No? Common hepatic, excellent. Okay? Now, the second part which bleeds a lot is in the stomach and the lesser curvature. Which artery goes there? These are both questions, especially for USMLE 1, because they want you to know the anatomy. Yes? No. Short gastric artery. Left gastric artery. Left gastric artery. Okay? I'll show you the picture. See the anatomy? See what are, let me just remove it so you won't be able to see. What are the branches of the celiac artery? Anyone knows? How many branches has?
3 branches.
Okay.
Gastroduodenal.
No. Branches of the celiac. No? Hey, what's the name of them?
Superior and central.
Which one? Ahsan, this is one. What's the other two? No? Left gastric. No? Ahsan. These are the 3. Here, you can see them here. So you won't forget them. This is the celiac, common hepatic, splenic. So remember it like this. One goes to the right to the common hepatic, one goes to the left to the spleen, and the other one in the middle to the stomach. Left gastric. The problem with this vessel, that's a big one, and with gastroduodenal artery, which is a branch of the common hepatic. And that's why you see, this is what they ask you in the board. Where are the 2 sides which are bad outside, that they can bleed and they can recur to bleeding? Posterior wall of the duodenal bulb, lesser curvature of the stomach. This one because of the left gastric artery, this one because of the gastroduodenal artery. Those are, believe me, in the Norse family you will find questions like this. This is very common. They love it because it has pathophysiology in it and anatomy. So you will know why this is happening. Okay. One other thing I wanted to go over, and this is very important to focus. If someone is coming, and this patient, which I wanted to present it in the beginning, I'm going to just say, the patient had pancreatitis. Came to Econ. The patient came with pancreatitis to the hospital because of alcohol. What other causes of pancreatitis? So you answered many questions. Let me answer one. No, just once again, see this side. The right side. Yes. نعم. Gallstone? أحسنت. The gallstone. What else? Give me only 7, please. Infection. Which infection? Which infection can cause pancreatitis? Which virus? Mumps and coxsackie. Okay. Any other cause? Alcohol, of course. Alcohol, yes. Iatrogenic. What else? Sorry?
Animal bites.
Which animal bite? Kharoof مثلا? Scorpion bite. Okay. Anything else? Hypercalcemia. Anything else? Cystic cystic fibrosis causes more chronic pancreatitis. Anything else for acute?
Hypertriglyceridemia.
أحسن hypertriglyceridemia. Anything else?
Drug abuse.
الدراج ابيوز اوكي مو كل شيء يعني بس الالكوهول دراج ابيوز. malignancy أحسن. Okay, anything else? By the way, anyone who's 50 years old or above comes with a new onset of acute pancreatitis of unclear etiology. يعني المريض doesn't drink, no stones, no hypertriglyceridemia, no hypercalcemia, no trauma, no ERCP before, come with the new onset pancreatitis. You have to rule out cancer. Or anyone who comes with a new onset diabetes, high, يعني مريض مو diabetic. A few days ago, a nurse came to me. She told me my husband was fine, never had diabetes. His year all of a sudden is blood sugar 400. You have to think about so new onset diabetes or worsening diabetes. Yeah, someone diabetic who has been on regimen for a long time, all of a sudden, not controlled. You have to think about pancreatic cancer. Those two conditions, middle age, with a new onset diabetes or worsening diabetes, that's one. Or someone coming with a new onset of acute pancreatitis of unclear etiology. That's the second one. You have to think about cancer. Now, COVID-19, absolutely, absolutely. COVID-19 has several cases. Yeah, absolutely. Yeah. Anything else? Malignant hypertension. Oh, yeah, there are very rare causes. I don't know about malignant hypertension. Shock definitely cause that. But they are not very common. So the question is, what is the treatment? Yeah, it's okay to go a little bit out of the GIP, but it's important. You know, I will come to GIP related to pancreatitis. What is the treatment for pancreatitis? Yes? Yeah, so what is conservative mean? Okay? You have the three main ones. Nothing by mouth. Pain medication, IV fluid. Okay? I'll ask you a scenario. Someone just came last night with acute pancreatitis. The patient has high temperature and has high WBC, severe abdominal pain. LFP is normal, liver function test normal, but the patient is febrile with high white cells. Do we give antibiotics or not? Acute pancreatitis, new onset, high WBC, high temperature. 13,000. Neutrophils. Do we give antibiotics? Yes. اسمع نص الجواب. بس الانسر هو when people come with acute pancreatitis, there is systemic inflammatory reaction. فطبيعي المريض يكون عنده فيبر وعنده high white count with acute pancreatitis. This is inflammatory, not infectious. إلا في حالة واحدة. There is only one condition when someone is coming with pancreatitis on day one, you give antibiotics. Do you know which condition?
Surgery complication?
No. Someone is coming. Yes. No. There is one condition. You give antibiotics. I have a broad question. You know, in the beginning, if there is only acute pancreatitis,
If it is associated with bacterial infection.
that's how you get it. In pancreatitis, there are two types of pancreatitis. One of them called interstitial pancreatitis. The other one is necrotizing pancreatitis. How you differentiate between the two? How you will know this patient has interstitial, that patient has necrotizing? By doing? I mean, now, let me go then on a question back. How do you diagnose pancreatitis? The criteria, what is the criteria? How do you make a diagnosis? Yes? There are 3 things. You need to tell me 3 things. And you choose 2 out of 3. That's a guideline. It's not my opinion. There are 3 things. You have to have at least 2 of them existent in the patient. What are the 3 things? One of them is clinical, the other one is lab, the third one is image. So what do you need to see? Sorry? لا, answer criteria, not for diagnosis, for prognosis. How you diagnose? أنت هسه عندك مريض جاي من ER عنده abdominal pain. اوكي؟ والمريض افرض انه احنا ندري المريض عنده ستونز. How are you going to know if she has pancreatitis or not? No? Okay. Let me just get, yes. Abdominal pain. Right, when pain you go to the back and the pain doesn't have surgical signs. يعني ماكو rebound and guard. So that's the abdominal pain. That's the clinical part, okay? Ahsan. So when we do the CT scan, we will see there is inflammation. And Ahsan. This is the how we diagnose. Clinically, مريض عنده symptoms. Lab, الاميليز 3 times more upper normal level. When the CT scan shows up, do you need 3 of them? No, you need 2. 2 out of 3. هذه أولادي بناتي لا هاي لازم تذكروها لأن this is they're going to ask you in the board about it. يعني أعطيكم مثال. If someone comes with an amylase of 400, is that pancreatitis? We don't know. What do you need to ask? No, you need to ask what's the normal. If I don't know the normal, then some places the normal 50, some places the normal 300. So before you say this is bad, I see this all the time. واحد يجي عند الاميليز ماركة 500, الراوي النورمال 400. This is not pancreatitis. The pancreatitis, you look at the normal. What's the normal? If the normal patient more than 3 upper limit of normal, يعني إذا هي 500 normal لازم يكون زيادة أكثر 1500. 3 times upper normal. إذا 50 لازم أكثر من 150. So you need to know the normal. بس السؤال is every high amylase means pancreatitis? No. What are other potential causes of high amylase? خط النص. تكبر يتمين الخط اليسرى بين الناس. Is there any causes for high amylase aside from pancreatitis? أكيد الإنسان that's one of them. Which one? Sure. Esophagus rupture. إذا في esophagus rupture, there will be some pleural effusion. Which side? Right or left? Usually. واحد عنده برهة and there is a pleural effusion. Right or left? Most of the time. Left. لأن الإسوفاجس من على الليفت قريب عليه. وإذا if you tap that pleural effusion, what are you going to find in it? High amylase. بالفلويد يعني. High amylase. ليه؟ ليش بس amylase مو لايبيز؟ نعم؟ لأنه هذا الاميليز ينجح. سليمري هذا الاميليز مع سلايدة. فاللايبيز يكون نورمال. بس الاميليز عالي. حالة ثانية تسمى left sided pleural effusion. فإذا واحد عنده fistula between the pancreas and the pleural. بس ذاك amylase لايبيز عالي. مو بس الاميليز. Okay? So this is something to keep in mind. Okay. Let me ask you this question. When we talk about someone has pancreatitis, how do we differentiate between interstitial versus necrotizing pancreatitis? Anyone knows? CT scan. What do you see on the CT scan? It has to be CT scan with IV contrast, no oral. Why? Because if there is interstitial pancreatitis, you will see the pancreas will light up. But if it's necrotizing, it's dark, then the contrast cannot reach it. It's important to differentiate. It's important to differentiate between necrotizing and if the patient gets infection in the pancreas, when does it happen? What time? What time is going to happen? Okay? Okay. The question is, if someone has pancreatitis and the pancreas necrotizes, get infected, when does it get infected? Usually about 5 to 7 days after. Why? Why there is delay? Many times it's because of our problem. What we do when the patient comes, we put the patient in PO. When you should start the feeding for a patient with pancreatitis? Anyone knows? Again, the married and the pancreatitis. Sorry? By mom. You start sooner than later. You don't delay it. يعني the minute the patient tolerates something, you can ليش؟ لأن يصير عنده bacterial translocation من الgut to the GI tract, then it gets to the pancreas. So, my question is this. This patient went home, came back with GI bleeding. What could be the cause of GI bleeding in someone who had pancreatitis? Anyone knows? Okay. I will tell you this just in a few minutes. But let me go first on the most common cause, and then I will come. This is the second one. Peptic ulcer disease. If we know the patient has peptic ulcer disease and they are bleeding, what do we do for it? What's the treatment for peptic ulcer disease? لا, مريض bleeding. Stabilization, number one. Yeah, resuscitation. Okay. If the hemoglobin is 6, how much blood do you want to give?
4 minutes.
What is your target?
10.
8.
No. See, the literature and the guidelines, there are two types of blood transfusion. There is the liberal and there is the restricted. The current guidelines, you don't do liberal blood transfusion. Then your outcome worse. So what is your, إذا المريض الهيموجلوبين مالته 10 and came with a GI bleeding and the hemoglobin now is 6. How many units you would like to give? أنت بالمستشفى أو أنت بالمستشفى والمريض عندكم الهيموجلوبين ماله 6. قبل ما يكون, before you tell me how, if you give 1 unit of blood, how much the hemoglobin going to go up? 1. Okay, so this is 6. How many units you want to put? Which means what's your target? No, the target is above 7. Yeah, if you make it 7.5, that's fine. Make it 8, that's fine. The less, above 7, the better. Then in study, that's what they did. They had a group of patients. This was almost, not recently, but maybe almost 7 years ago. Very well studied. Group, they did liberal transfusion. Yeah, maybe 6, they did 4 units. Push it up to 10. And they took a group, they went with the restricted resuscitation. They give only to push it above 7. If someone has cardiac, they push it above 8. But without cardiac issue, at risk of hypoxia, exacerbating the cardiac, above 7. So you guys, so if the patient comes and their hemoglobin is above 7, you don't transfuse. Unless if someone is still ongoing bleeding and you know it's going to go below 7, then you give. But otherwise, you don't transfuse below 7. This is the current guideline. Okay? So the first thing we say, do you resuscitate? Then, do you do endoscopy? Yes, if there is GI bleeding, you need to give endoscopy. If you do endoscopy and you see ulcer, do we have to treat it or not? Sorry? If we do the swab and we find an ulcer,
What is the answer?
either one. So, okay. So, anytime there is ulcer, there are a few things needs to be done. Number one, you need to know if the ulcer needs to be treated endoscopically or not. How do you treat it? Usually 3 modalities. Inject it, cauterize it, or clip it. It has to be 2 out of 3. But when do we decide that? I'll show you one thing. This is very important slide. Ahsant. Depends on the status of the ulcer. And this is the status of the ulcer. Okay? This is very important slide. If the ulcer is a clean base, like the first one, yani clean, there is no doubt, nothing, we don't treat it endoscopically. But we do 2 things for it. See, when there is ulcer in the duodenum, and there is ulcer in the stomach, there are 2 things same we do, and 2 similar, and 2 things different. What are the 2 things similar we do whether it's ulcer in the duodenum or the stomach? Number 1, we start with PPI. Any ulcer, you have to start PPI, whether it's duodenum or stomach. So, the second thing is what? No. You take a biopsy from the stomach. From the stomach.
5 pieces.
For what? Why you don't biopsy? Not from the ulcer, from the stomach. Why are you taking biopsy?
The effective cells.
No, not malignancy. Ahsan, for H. pylori. Any ulcer, whether it's a duodenum or whether it's a stomach, you need to biopsy the stomach to know it's H. pylori. Because that's the common cause, one of the common causes, ancillary H. pylori. So any ulcer, are you with me? Any ulcer in the stomach or duodenum, you do those 2 things regardless. Number 1, you treat with PPI. Number 2, you biopsy the stomach. حتى لو الألسر بالدوادنم. لأن ما H. pylori بالدوادنم. H. pylori ده أنا حتى لو cause of the ulcer بالدوادنم، H. pylori بالstomach مو بالدوادنم. You check H. pylori biopsy of the stomach. Is there any other way you check for H. pylori? Yes. شنو هي؟ Breath test? شنو اسم breath test? Urea breath test. And what else? Stool antigen. Okay. In which situation the stool antigen is better than urea breath test? I'll show you some stuff. If someone has gastric bypass, لأن الجاستريك بايباس المعدة معزولة، اليوريا ما راح تطلع. So you have to check the stool. فإذا واحد عامل gastric bypass and you want to check for H. pylori, you cannot do it with the biopsy. Then exclude it. Urea breath is not very accurate. Then exclude it. You do the stool. Okay. So that's for H. pylori. Those are the 2 similar, whether it's a gastric or duodenum. What are the 2 different between the duodenum and the stomach? What are the 2 different things? One of them, if the ulcer is in the duodenum, you don't biopsy. Yeah. If the ulcer in the stomach, you have to biopsy the ulcer. That means you do 2 biopsies. One for the stomach, elsewhere, for H. pylori, one from the ulcer, to rule out malignancy. That's one difference. No biopsy for duodenum, biopsy for the gastric ulcer. What's the second one? The second one? Yeah, the second, the management. I'm talking about the management. The second one is you have to rescope the patient who has gastric ulcer in about 4 to 6 weeks. Why? Because you have to make sure the ulcer is gone, and the biopsy can false negative. But you don't re-biopsy, you don't rescope the duodenal ulcers. But 2 things similar, PPI, check H. pylori. Two things different. Gastric ulcer in biopsy, you don't have biopsy to abdomen. Gastric ulcer, you have to rescope to make sure there's complete healing. H. pylori, if it's positive, the guidelines now, you have to check for eradication. Yani if you check H. pylori, you treat it. Once we are done with the treatment, we have to check, is it gone or not? When do you check? When? Not sure. No? That will work 1 month after the end of antibiotics, 2 weeks after the end of the PPI. Then now being on PPI or on antibiotics, you will get false negative. فمت بيه. فالمريض لازم يكون خلص العلاج مالته. والعلاج عادة PPI وانتيبيوتكس. فيكون على الأقل شهر كامل من الانتيبيوتك and 2 weeks from the PPI حتى يتشيك for H. pylori. هذا بالنسبة للألسر. إذا الألسر بيها اللي هو هذا أكو بيها vessel أو يسموها spurting blood, we have to either clip, cauterize or injected with epinephrine. Remember in the exam, the epinephrine is only for arterial bleeding. And when I ask the student, okay, someone has varicose bleeding, what do we need to do? They tell me give epinephrine. Epinephrine doesn't work for the vein. It needs vessel, it needs muscle. The vein ما لي muscle. It works for arteries. واحد عنده arterial bleeding, you can give epinephrine, not for vein. So, this is for the ulcer. أرجع للسؤال مالت الأولاني. If someone had pancreatitis, why the patient is coming with GI bleeding? أما أنتوا ليش تتقدمون؟ ما الكلاس كلها فارغة كده. لا شوف إيه اتفق وياك، تسمعها من متأكدين. لا بس براحتك مالك. أوكي. What could cause pancreatitis?
Doctor, by damaged cell of pancreas?
لا خلي أقول لك احنا لما نتكلم على الفاريسز when we talk about varices واحنا قلنا الفاريسز thank you very much for coming for لما نتكلم عن الفاريسز اكو نوعين صح؟ فاريسز بالإسافيجس وفاريسز وين؟ elsewhere. It could be in the stomach, it could be in the duodenum, it could be in the biliary tree, it could be in the colon, in the rectum, anywhere else. It could be anywhere. But if the varices are in the esophagus, it means there is portal hypertension. Which side? On the right side. And cirrhosis. هذه يمكن ما اعرف كيف هذا اخر فكره بس اريدكم تنتبهوا لي لان صدقوني هذا ان شاء الله 5 دقائق راح اخلي السلايد حتى تشوفوا حتى نقدر نحكي اثنيناتنا. هذا المريض This is a real patient, one of my patients some years back. The patient came, I will tell you about another patient, very similar, 12 years old. 12 years old. She had motor vehicle accident, ended in the pediatric ICU because she had pancreatitis. Why she had pancreatitis? Trauma. She got blood trauma, she got pancreatitis. 5 days later, she bled. The pediatric gastroenterologist went and did the score. And she started passing medicine. When she bled, passed the score, he found an ulcer in the stomach. He didn't do anything, put her on PPI. 2 days later, she bled again. So he asked me, and the pediatric gastroenterologist, they don't do a lot of intervention, they don't see that many bleeding. So I asked him to go with him, so I went. When I passed the score, I saw ulcer in the stomach, And something similar to this, raised. What does that mean? It's a virus. Why someone had pancreatitis gets virus in the stomach? No esophageal viruses. No esophageal viruses. Only in the stomach, isolated. Why? Now, I will come to answer that. When someone has cirrhosis, where are usually the varices? Most of the time in the esophagus, with or without varices somewhere else. It could be esophagus with the stomach, it could be esophagus with duodenum, but in esophagus almost always. Mitch, what is the pathophysiology? There is no blood can go through the liver from the portal vein. How does the blood go out of the liver? Hepatic vein, free hepatic vein. The blood exits. So blood comes to the liver through portal vein, exits the hepatic vein. The liver, عادة لا يسبان, but it becomes like a rat, and the blood ما يقدر through. فيروح على القلب. يسبب esophageal with or without stomach. That we call it right-sided portal hypertension. And the problem is in the portal vein and in the liver, and both of them in the right side. Meanwhile, when someone has pancreatitis, they get left-sided portal hypertension. Yeah, if you try to go to fix the problem in the liver, nothing gonna happen. You're not gonna have the patient. Which mechanism? Anyone knows why pancreatitis causes varices in the stomach? Yes. بس هو البورتال نورمال. يعني البورتال vein is not occluded. What is the closest vein to the pancreas? أحسنت. Yeah, splenic vein thrombosis. It's very common for acute or chronic pancreatitis to get splenic vein thrombosis. You know, the pancreas and splenic vein beside each other. From the cerebral, what happened? Clot. بالسplenic vein. وإذا صار clot بالsplenic vein شو يصير؟ I'm going to show it to you. Okay. شوفوا هذا picture. I want you just to focus on it because this is very important as a pathophysiology. If you understand it, you don't need to memorize it. This is the هذا الليفر هنا والspleen there. Okay? So what happens? Okay. With portal vein. This is all right side, right? Spleen on the left side. Now, if there is a liver problem, you see the sign that block the blood supply. How does which vessel gonna feed the varices in the esophagus? You can see there. Left gastric vein. So the esophagus, and this is board question. They will tell you that which vessel lead to esophageal varices. You need to remember, this is the vessel. It can give esophageal and gastric when it's right-sided portal hypertension. This is very important to remember. لأن أحيانا لما نسوي tips, you know what is tips? Have you heard about tips? The transjugular, transhepatic. Now, the shunt, it will work for this side, but it's not going to do anything with the one I just going to tell you. Okay? So you see here, the blood supply will go through the left gastric, the liver blocked. The blood cannot pass, it's making a detour. And then it caused the esophageal varices, they're up, and it can cause gastric varices. Could gastric, but esophageal must. That's when the problem is here. However, if someone has pancreatitis, this is the vein would get clogged because the pancreas is right here. So now you have splenic vein thrombosis. What does that do? What is the name of the vessel that the collaterals will go through? The short gastric vein. Remember? Short gastric vein for left-sided portal hypertension. Left gastric vein for the right-sided portal hypertension. The treatment is different. So what is the treatment for the left-sided portal hypertension? Either you do splenectomy, because what happened now? The blood goes to the spleen with the artery, it cannot come out, spleen gets big. Blood goes to the spleen, through the artery, through the splenic artery, it cannot come out, get bigger. If they remove it, it can get bigger. And there is another procedure, but that's one thing. So remember this etiology. So that's why you see gastric varices, but without esophageal varices, because that does not reach there. So it's important to know, isolated gastric varices after pancreatitis, that's something related to the splenic vein system. It is still called portal hypertension, but they call it left-sided portal hypertension. However, if the liver is involved, that's right-sided portal hypertension. I think I'm going to stop here because my time is over. But if there is any question, I really thank you very much for staying. And I hope you learned something. You guys are very smart. And inshallah, you all will be very successful in your career. Inshallah.